space where beauty meets authenticity and transformation is not just a possibility, but a promise. I'm absolutely thrilled to introduce you to someone truly special, Dr. Rukmini Vinya Rednam, the compassionate force behind the countless remarkable transformations in the vibrant city of Houston, Texas. Picture this: every curve, every contour crafted with care and expertise, not just by a board-certified plastic surgeon, but your very own cheerleader for self-discovery and confidence. Get ready to embark on a journey where we explore the art of science of feeling your very best self. This isn't just a podcast. It's your cozy corner of empowerment and inspiration. So pull up a chair, pour yourself a cup of kindness, and let's dive into the Confidence Doc podcast with Dr. Rukmini Vinaya Rednam.
Welcome back to the Confidence Doc podcast. I am Dr. Rednam. I am the Confidence Doc, and I'm here in Houston, Texas. I'm a board-certified plastic surgeon, and I have with me today a really awesome guest. I have Dr. Monte Eaves. He is a board-certified plastic surgeon. And how long have you been in practice, Dr. Eaves?
For quite a while, 30 years.
So just for a little bit. He's been doing this.
Yeah.
I'm going to brag a little bit on Dr. Eaves. He is a former president of the American Society for Aesthetic Plastic Surgeons, and he also served as a director for the American Board of Plastic Surgery. Just to name a few of his distinctions. But today I have him on as a special guest because he is not only a plastic surgeon, but he is an inventor. So tell us a little bit about how you first got into plastic surgery, Dr. Eaves.
It was pretty organic. I grew up building furniture with my dad, and his best friend happened to be a plastic surgeon. And one day we're sitting around in the shop just doing stuff, and he gets a phone call. And he said, someone has amputated their thumb accidentally in their garage door. I'm going to go put it back on. You want to go watch? I was like, well, sure. It was a little bit different back then. The head nurse said, don't touch anything, wear this, and everything. And I was hooked. Just kind of the combination of the humanity of it, what we do to take care of people, how important it is to them and their families, whether it's reconstructive or aesthetic. But at the same time, there's certain, technical and things, but there's this artistic component, as you know so well. And that's what gave me really the hook to get into plastic. So after that was like in late middle school, and it didn't change.
Oh, wow. So that was very early on.
Yeah, I was fortunate to have the exposure.
So because you knew from such an early age, what was your pathway to get to your plastic surgery training?
Well, I did work once I got to high school. I worked in the hospital in the summers. I was actually, my first job, I was in a neurosurgery ICU as an orderly. So I transported people, cleaned people up, all those sorts of things that we do. But you learn a lot, right? You're around patients. You understand kind of how the flow of the world works. So that was really important. And then once I got into medical school, of course, you have rotations where you can go spend and do that. But because I had been in the operating room, because I'd seen it, because I was familiar with it, I think I did have other things. Orthopedic surgery interested me quite a bit. And I thought about pediatric surgery, but it was always came back to plastics.
I think that's kind of I feel like a lot of plastic surgeons kind of see orthopedics a little bit too, because even I had an interest in that. Mm-hmm. And then we see some of the closures and things, and we're like, maybe we would like to think a little bit more than just the bones sometimes. Not in any way putting down our orthopedic colleagues, but it's a bigger picture we see of the body sometimes.
Yeah, although to me, I think the thing that really ties together is kind of a sense of function and a sense of geometry. Right. So when you're in orthopedics, you have to get, things in the appropriate alignment and mm-hmm. and the right, length and arc of rotation and things like that. But we do the same. We're building a breast reconstruction. We need to get the right curves. We need to get the right shapes, so forth. Same in body contouring or pretty much anything we do. So
that's very true. We're just working with slight different materials.
We're on different sides. We're the soft tissue guys. They're the firm tissue guys.
Exactly. So once you did finish your training and you got into practice, were you in academics or private?
I moved around a little bit. I did my general surgery training in Texas, actually up in Dallas at UT Southwestern. And then I landed at Emory, which was a great place to do plastic surgery training. I loved it. And I ended up staying on the faculty, my first job there for 3 years. Then I went into private practice. But as you know, one of the kind of really cool things about plastics is you can kind of do both. You can do academics while you're in private practice. So I was there 15 years at a great group, Charlotte Plastic Surgery, and then moved back to Emory in 2013 and was there full time until 2-3 years ago when I transitioned to doing most of my time with my current project.
And during the time that you were, I guess, actively practicing a lot, what would you say was your focus, or the things procedures you enjoyed doing the most?
Well, it definitely changed over time. When I was first out, I did a lot of breast reconstruction. And then I started doing more and more aesthetic surgery. I found a home in the Aesthetic Society. It was my kind of my academic place, my academic home. And so I had a lot of exposure there. And one of the early things I was involved in innovation was endoscopic surgery. And a lot of the endoscopic procedures were really well suited for aesthetic. So that was, I really ended up there. When massive weight loss started to become more common with the Roux bypass, very late 90s, early 2000s, I kind of decided I like that. I thought it was very interesting. It's challenging in a lot of ways because the tissues have changed so much, but it's so life transformative for people. It's just hugely rewarding to do. So what I found is that I didn't really have the bandwidth to do both, to do a lot of breast reconstruction and then to do a lot of that. And then the last 10 years of my really active private practice was pretty much all aesthetics, including the massive weight loss.
So you mentioned that endoscopics is when you first started kind of becoming more, or not really becoming, but getting more into the side of also being an innovator. How did that spark come for you?
Um, well, I think part of it was, again, going back to as I grew up with my father. He was an engineer, and a lot of times we'd be doing some project, building something, adding on to the house, and it's something. So, like, Monte, how would you do this? Can you draw out what you would do? Why would you do it that way? How would you support it? So you start thinking in terms of these, and you feel empowered to think about things. And then when I first got to Emory, it was right after endoscopic procedures had become common in general surgery, so like gallbladders and so forth, but it wasn't at all into plastic. So I ended up just through happenstance in the lab, and I ended up developing some equipment to be able to do those. And I loved it. I love working with the engineers. I love that design thing. And I've been hooked ever since.
So a lot of it is your engineering mind. It sounds like your dad really kind of helped you develop as
Yeah,
well.
there was a big influence there for sure.
So tell us a little bit about your current project.
So starting in about 2005, I was really intrigued with how we can do better with the way we close wounds. Plastic surgeons, as you know, you do this, you talk about this, and you do this every day in your practice. We care so much about doing a great job with how we close wounds, how we do things to help control scar, and yet so much of it is out of our hands. And then sometimes we'll go and we'll have things like wounds that open up or things like that. And we would see this sometimes in our cosmetic, but certainly in our reconstructive patients as well. And it just seemed kind of crazy that we're still primarily relying on sutures, which, are documented back 5,000 years. It's like there's got to be a better way.
Yeah.
So I really started after a period of time, and I did feel empowered because I'd had a couple of devices that I was able to get licensed to different companies. And so I had somewhere around 40 ideas that I worked on, and some of them were just awful. You discard them, you throw them away. And that's a big part of the process is you kind of want to be your idea's toughest critic. And the current project, the BRIJJIT, is the one that just kept floating back up to the top. You couldn't sink it. It just kept going. So That really started in 2010. And then over the last 3 years or so, we've gotten to the point that we're able to have it out and doctors can use it.
And, I was excited having the show because I am obviously a big fan of BRIJJITs, and I've seen like how they can really improve our closures with really not adding a lot of time, which is something pretty amazing. Because there are a lot of devices currently on the market that are supposed to be for helping appearance of the incision, but I've yet to really find one that doesn't add a lot of time and doesn't add discomfort. So when you were designing it and kind of thinking about these things, what were your main goals with the product? Obviously, beside the obvious of having an improved closure.
Well, that is actually an excellent question. I love it because I think for us as plastic surgeons, we pride ourselves on being the wound healing doctors and understanding how incisions heal. And so the things I was looking for, what are the things that we know that promote good healing and good scars, and what are the things that compromise that? So, for instance, we know we want it to be as atraumatic as we can. We don't want our method of closing the wound or supporting the wound to actually cause more damage. So you think about sutures, you're taking a needle, you're jamming it, staples, you've got these things. So you want to make that. So we want to say it needs to be minimally invasive. It needs to not damage the tissues at all. I think one of the biggest things that we always think about is tension. There's been over the last 20 to 30 years, a huge increase in the understanding of how tension causes wounds to have problems, both early because it inhibits the blood flow when your body needs it to heal that wound, but then later on that tension really stimulates the body to lay down more scar by a variety of different mechanisms. It even changes that tension, changes your gene expression so that your cells want to put more collagen down, and then that tension also causes ongoing inflammation that keeps that scar red and thick, and some people can lead to hypertrophic scarred keloids. So we said we have to control the tension. And then some other things, like we know that materials that aren't native to the body, inside the body, foreign body, those can contribute to low-grade infection or inflammation and so forth. So we had kind of this list of characteristics, and then we wanted to design to as close as we could get to the ideal as possible. And I think, in the inventive process, that's, a very good strategy. You want to know your subject area, want to know what you're doing, and then know where the problems are as best you can.
And I think that's just the key. And I think that that's what I've even been seeing with when I use this device. I know hyperpigmentation of scars is a big issue. And, we actually had a lady who had had a tummy tuck with somebody else. She came in for a revision, and we did a test section to remove and see if we could get the scar to look better. Even though her scars were flat, they were very pigmented. And by using this, we used it for 8 weeks. We actually reduced the amount of pigment significantly in her scar, which was pretty amazing because there was less inflammation because there was less tension. Yeah. So it was just following. It's just you taking those tenets and we're just going backwards. So it made sense why her pigmentation was less. And for those of you listening, I'm talking about post-inflammatory hyperpigmentation. And those more prone to it are people with darker skin colors and certain ethnicities. And so if we're reducing inflammation with something like this tension relieving device, then we should be improving all the things that are subsequent to having that down the road.
You're absolutely spot on. I think we're early enough in this, we're still learning, which is great. We're seeing some really great results, but we're learning new things. So just an example, we had a surgeon in Tennessee that placed one on a patient with keloids. This patient had multiple recurrences and just kind of wanted to see what it would do. And we do know that keloids and hypertrophic scars are driven by tension. And with nothing but that, in about I think it was 6 weeks, there was about a 50% reduction in the keloid without shots or injections or radiation therapy or something. So, we're not there yet, but we're still learning, and there's so much untapped potential for really understanding if we can control tension and really respect these core healing principles, we can change the way things, and that's kind of the fun of innovating and doing something, right? Can we change the world a little bit?
That's pretty amazing. I mean, everything in plastic surgery is if we can focus more on prevention versus then fixing, we can get so much better results.
Absolutely. And then sometimes we also want to be able to fix very early. So, for example, sometimes somebody's healing well, and let's say a deep stitch becomes infected and works its way out. If you can mitigate that and make that kind of a nothing, a little tiny event rather than a big deal, it's great. So, one of the things we found is, for instance, if people start having a late wound separation or something like that, we can support that with the device, take the tension off, and they can go on to heal without having to go back to the operating room or without having to have a scar revision later.
So I'm assuming one of the challenges when you invented this device was how to make it stick.
Yeah.
And how to make it stick without causing issues and causing other inflammation, because there are a number of products that we do use on the skin for like glues and things like that. But
Mhm.
I've personally found my hands that I have a lot of patients who will have reactions to the adhesive. So, what kind of challenges did you see while you were trying to figure out the proper adhesive?
Well, I think that's the magic to a certain extent. So I think there are a couple of different parts to it. One is the adhesive itself. We had to go to one of our partners, a brilliant chemist, adhesive engineer at a great company that really helped us develop something. We needed something that was very strong and sheer. In other words, it wouldn't slide, but it needs to stick really hard and well. And that's actually kind of hard because a lot of times the things that are stickiest are gooeyest and they slide. So that was part of it. Another part of is that we want it to be very pure. So we made sure there weren't, any unnecessary additives, because sometimes it's the additives that can cause allergic reactions and so forth. So that's on the allergy side. The other side to it is one of the challenges is we're dealing with forces. We are putting movement and forces on the skin, and those forces can cause irritation or blistering or pigmentation like you just talked about if we don't control them. So one of the things that we really worked on is the way that the device goes on. So I don't know, for those I can show here in a second, for those that maybe are on the visual part of the podcast, but the part in the middle sticks first, as you know, and it advances, and only then does the outside go down. And what that means is it's a way that we learn to disperse those forces so that they're much less likely to cause skin irritation or blistering or something like that. So we looked at our first over 1,100 patients that were done. We did a survey of our users, and it was less than 0.2%. It's not zero. And there's some little tricks people can do to minimize that, but we've been extremely pleased because we're applying a lot of force to the skin. So there's essentially no tension left. And yet we're having very few issues or problems. And it's very comfortable to wear, as you know, and that's partially controlling those different forces. So it wasn't just the adhesive, it was also the way the adhesive was applied.
And then how did you kind of decide for materials for actually making the clip part of it? Was that something that you're like, okay, there's a standard type of plastic that we're going to use, or was that also something you really had to start at the beginning with?
Well, that's all starting at the beginning. So I think this is part of the fun, and it's also part of the challenge of a product like this, because there's really not a corollary device out there. So if you're building a new needle and suture, you start from a lot of knowns. It might be a new material, it might be have barbs instead of smooth or something like that. But for us, it was all new. So in terms of figuring out materials, again, you look at what criteria are going to work. So we said, well, would we want to make this out of metal? Metal's certainly strong. It can be shaped into anything. But then again, if you had electric cautery and it ground it out, could you develop a burn? Or, what would happen if you go through the x-ray machine at the airport, or who knows what? So we figured plastics, because you can take x-rays through it if that was needed, say in orthopedic surgery. It will not interfere with imaging. But then we needed a certain amount of flexion. It needs to bend. It's a dynamic device. And so it needs to bend. So we had to look at different types of plastics to have the right flexion. And then the other thing is we want it to be really clean. So the plastic we pick, the surface tension stuff that when you're in the shower, if you had any blood from your surgery after your first shower, it just rinses right off and they're clean. And I bet you've seen that in your practice.
Yeah, because they obviously don't want to increase infection risk by catching anything in there.
Exactly, or have just something sitting there for a long time.
And I could definitely vouch for any of the tension relieving kind of devices out there. It may help on the tension, but often they leave worse scarring on the perimeter because you're offloading that tension in another area. So this really is a very unique and innovative device. And for those of you who are watching on our YouTube, Dr. Eaves is going to demonstrate what it looks like because it's such an elegant, simple design, but it's pretty neat to see how it goes on.
So the device is called BRIJJIT. The company is Bridge Medical. We have two different sizes. We have the kind of workhorse. I'm sure Dr. Redmond, the one you used initially, a little bit larger. We have a new smaller one that is shorter and has a tapered end, so it will go around corners like the RELA and breast surgery and so forth. And they have an applicator. If somebody and interestingly, we have had several patients that had allergic reactions to other adhesives, and we actually do a test site. In that case, we can put it on and say, hey, wear this for 3 or 4 days, and if you have no reaction, we're good to use. And so far, nobody has reacted. But to prep the skin to do it, I'm just going to do a demonstration on myself. You won't believe this, but I've done this on myself before, like maybe 10,000 times. So what we do is we just rub a little bit with an alcohol pad. That's all that's generally required. The device comes on its little tray, and we take this applicator and we just snap it in. You can usually hear it, and it rolls right off. The pieces of plastic that support this and prevent the adhesive, they stay right here, and this is actually recyclable. That's another one of those things. You try to think all the positive things you can do and the criteria you want, then design to that. So if I hold it up, you can see the device. It has a central arch, it has these foot plates, and everything under here sticky, has this little gap in the middle. And these two little parts here that stick underneath are, we call the struts. And what's really important is you open this up, the backbone flattens and the struts rotate down and out. And it creates an arc of rotation so that when you apply this to your patient, as it goes back to its native shape, it will transfer that and actually not only reduce the tension on the surface, but do it underneath the skin or to the bottom of the skin. So if I put this on, let me make sure our camera's in the right place. Can you see? I'm going to squeeze, and then as you notice, see those center parts touch first. Can you see that? And then as I go, you see it starting to come together. That's taking the tension off, but the outside hadn't even touched yet. And the last thing as we finish, that outside touches, we just release, and a little pressure to set the adhesive, and that can replace a suture or a staple. And then you can see the tension reduction. You see the wrinkles, how they're changed, and you can see that it's averted. And that aversion is telling us that we got the tension off.
And it's funny, as plastic surgeons, we always know we want to get a good amount of eversion because as scars heal, and they pull in, and we don't want to have a sunken scar.
Yeah.
But I think it is funny, right? A lot of, most people, when they see it, they want your scar as straight as possible. We are always thinking in the future as plastic surgeons.
That's
so
right.
we want it to look good in the future. We don't want it to look perfect on the table. So this is just another way that we can further give that really good eversion to get that future good result.
Spot on, 100% agree. I think in addition, I think about those depressed scars as well, because they catch shadows, they don't look right, and we want to avoid that. But I think the other thing that as I've studied this and really tried to understand the physics of what's going on as these tissues move, is that version is really a result of the tension reduction. And when you push the tissue together, if it doesn't avert, this becomes now under compression, right?
Mm-hmm.
Compression, just like tension, can affect blood supply and so forth. And the fact that it can avert up relieves extra pressure. It's almost like this pop-off valve. It goes where it needs to be at a lowest pressure as possible. And that should really optimize the blood supply and the healing environment.
Yeah, like I said, it's just a really neat device, like how you thought through and designed it. I know that applications, we're talking about plastic surgery right now, but I know that you have been looking into other specialties where this may be some benefit.
Yeah, for sure. So plastic surgery is because this is our home and where we got started. But, as plastic surgeons, we very frequently work with other specialties to assist with things, potentially soft tissue wounds or flaps to cover areas and so forth, right? So our first foray, as it was outside of plastics, is in orthopedic surgery. And I think the real draw for us is our 2 clinical trials show a 90% reduction in wound complications. So the thing about orthopedics is they very often have pieces of metal, whether that's a replacement of a knee or a plate to treat a fracture or something like that. And if you get a wound that opens, or if that gets infected, it is a huge, huge problem, because infections are always much worse if you have an implant. We see it in breast augmentation or breast reconstruction if we get a thing. So that is where we're now, and we're looking and starting to get used, like in knee and hip replacements, foot and ankle surgery, sports medicine, shoulder, so forth. We're really interested in spine. Interestingly, spine procedures have some significant wounds. I think pediatric surgery is another example. It's really scary for kids, like if they have a laceration, to have a shot and everything. We've been able to do, if it's a simple laceration, be able to close these and really get that surgical quality, tension-free closure with in 60 seconds, and the kid's up and jumping and running around. So there's other examples, OBGYN, from C-section or hysterectomy scars and so forth. So we're still learning, and that's kind of part of the fun of it.
I didn't even think about pediatrics, but you're right. And, even if they do use something like skin glue, that's not very comfortable. It can be painful actually for the application. So that could really be some place where you're not only making, like you said, the scar look good, but you're actually easing both the child and the parent's tension a lot too.
Yeah, exactly.
So curious with orthopedics, when you're talking about joints, things like that, they want their patients to get up and move very quickly. Has there been any limitation by putting these devices on with that movement, or quite the opposite?
I would say quite the opposite. And it's a great question, because what you want to do is, again, you think of those criteria that you want to design to that are going to really give optimal performance. And one of these is that it needs to not restrict movement. So the example that was when developing this for me was the front of the knee, because if it can go from all the way to bent under your hip to all the way extended and not restrict movement, it's good. So as we place these in series, and there's a gap in normal tension or normal tissue in between, and that allows it to stretch and go. So I've actually applied these to myself. That's not post-surgical, but then go on a run. Or I've been on a rowing machine, and we've actually measured the tension on the wound, and we can show that even with flexion all the way, we're still offloading. So it allows the patient hopefully to have more aggressive physical therapy or more aggressive movement without the concern that their wound's going to have a problem.
That's really amazing. What do you think? What do you see for the future, Bridget? Do you think that the 2 sizes are where, this is where we're at? Or do you think that you might come up with new shapes for new areas in the body?
Well, we've got a whole R&D platform in the wings ready to go. I think right now, what we're really trying to do is to get the word out there, to get this in people's hands, to really learn, the very best uses, and really hopefully bring those benefits to patients. But we have additional sizes of the BRIJJIT device, and we actually have other devices that will similarly, all centered around relieving the tension to improve scars or decrease complications.
That's amazing. We look forward to being able to see kind of what new things your mind comes up with.
Yeah.
Are there other devices also that you kind of are working, or is right now this your focus?
Well, it is a focus. I mean, we've got, more than a half a dozen, concepts in the pipeline. But I think, one of the things that when you are developing something is you do have to have focus. So I think right now the thing is determining what's going to be the next device that's going to have the most impact for patients. So some of that's market analysis, where the unmet need's the greatest. Who could benefit from it. So that will kind of let you know how you prioritize those different elements in your R&D pipeline.
Is there anything that you would like to leave our listeners with about a bridge device at all?
Just ask their surgeons about it. Again, we're trying to change and give a tool for their conscientious surgeons to be able to offer, to bring something new to them. The fun of this is not doing a Me Too product, not doing something that copies something else, trying to do something different, and not something that's passive that just sits there and lays there like a piece of tape or something that is actually going to do something and empower patients and empower surgeons that way.
So I think that's I really just really in awe. I think it's really amazing, and I think in plastic surgery, there I was just talking with a scrub tech the other saying how everybody wants their name on something. So I'm just curious, did you decide not to put your name on this? You went with a totally different device name.
Yeah, I don't know. I didn't really think of it that way. Actually, my wife helped me develop the name of the actual device, and it does bridge over the tissue, and it sounds like BRIJJIT.
No, it makes sense. It could have been the Eaves, but it makes sense. No, thank you so much. Thank you so much for coming and sharing. I really believe in this product. I've seen firsthand what it can do. And so I'm very excited for the future of it. I think that plastic surgery, like we talked about before, is about thinking outside of the box and innovating and finding better ways to do the things that we've been doing for hundreds of years with more comfort for our patients and better outcomes.
Well, and I think that's something we pride ourselves, right? We are fortunately taught the thought process within plastics is one of innovation. We see different things every day, right? We see different wounds, or we see different things, or we're doing, a mommy makeover, and the breasts are totally different from each other. And we have to use innovation and constantly assessing our results and seeing, are we improving and getting better all the time? So that's the fun.
All right. Well, thank you so much for joining us, and thank you for our listeners listening in today. Once again, the devices we are talking about are called BRIJJITs, made by Bridge Medical. And we had Dr. Monte Eaves on today, who is the inventor of these devices. Tune in next week for the Confidence Doc, where we will have some more amazing guests. Thanks so much.
As we wrap up another episode of the Confidence Doc, I want to extend our heartfelt thank you for being a part of our community. If today's conversation resonated with you, remember that Dr. Rednam and her team are here to support you on your journey to self-confidence and beauty. Your story is unique, and it's our privilege to help you create the masterpiece that is your life. If you'd like to book a consultation with Dr. Rednam, you can visit her webpage at drrukminirednam.com. Fill out a contact form, and one of her coordinators will get with you accordingly.